Hello everyone. Today we will discuss about excision of intraventricular meningioma. These are lesions present at the deepest part of the brain, which requires utmost preoperative planning and strategy. Our patient was 55-year-old female, presented with headache, vomiting, speech disturbance with altered sensorium. She had right hemiparesis with low GCS. MRI showed lesion which was T2 ISO2 hypointense, T1 hypointense, which was contrast enhancing, situated in the left lateral ventricle at trigonal region, causing focal enlargement of the left lateral ventricle of the temporal and occipital horn, abutting the brain superiorly and posterior cortices. Our approach was to reach the lesion with the least cortical handling and expecting the postoperative deficits. These are the approaches planned to reach lesion transsulcally from the intraparietal region. As we know, the blood supply from the intraventricle, this area meningioma from the anterior and posterior parietal arteries. Left parietal occipital craniotomy and left parietal transcervical approach was done. Patient was put in 3/4 position, head being on the right side, lower fixed to the pins. As we can see in the picture, the craniotomy and approach. Transcervical approach will be helpful, avoiding the venous and brain handling at that area, avoiding vascular and mechanical injuries. We can see a transcervical approach as we discussed previously with minimal corticectomy, which is not a mandatory otherwise. Our present corticectomy was done significantly posterior from the sensory cortex, also as superior as possible to avoid the optic radiation injuries. We can see a lesion present subcortically, which was done at the depth of sulci. It was pinkish vascular, well capsulated, so softofibrous, with well defined arachnoid layer. There was significant file feeders all around. As a routine meningioma excision, initial decompression was attempted. Then we started dissecting from the surrounding area, keeping the arachnoid plane, coagulating the pale bleeders as and then. Tumor decompression internally is mandatory to avoid unnecessary enlargement of the corticectomy and traction. Later, meticulous coagulation on the tumor surface, sharp dissection and excision of the cutting of the bile vessels is needed. To continue the plane, keep on adding the patties or cottonoids at the junction of brain and the tumor, starting from the inferior pole. Gradually we followed it anterior surface at the depth, staying on the surface of the tumor. Gentle traction to visualize the junction of brain and the tumor, and following the basic rules of tumor coagulation at the surface and packing the junction between the tumor and brain was continued. As you can see, very minimal retraction was needed to keep the brain away rather than excessive traction on the surface of the brain or at the depth. We can see surface vessels like veins and arteries are hardly at the traction or tension. we have come to the superior surface of the tumor, continuing the coagulation on the surface, rotating at different axis is allowing us to see the tumor circumferentially. We're gradually reaching the posterior surface. Coagulation at the depth will be done at the later stages. The posterior surface of the tumor is being separated from the brain at a retinal plane. Gentle traction to see the plane and the tumor surface being done. As we see, there is a minimal bleed as we are continuing to use coagulation on the surface of the tumor and maintaining the field avascular. Tumor was removed in piecemeal initially, and a large chunk was excised at the end by separating from its feeding vessels. Gentle removal from the field has given us a large chunk, confirming the complete excision. As we have seen, there is a minimal bleed at the base or attachment of the tumor, which was controlled by padding with or layering with surgicel and gel foams. Almost every time these venous bleeds will be controlled by hemostatic agents and little mechanical compression using the patties, and thorough irrigation will clear out the blood, also help for the hemostasis. Now we can see there is lax brain with meticulous hemostasis, which is achieved under the microscope. Now that no retraction is required. Again, padding with patties and waiting patiently at this stage is mandatory. Thorough irrigation will help for seeing the new bleeders or also clearing the old clots. We can make out transcercal route of our entry towards the tumor. Vein appears to be significantly lax and pulsating. After completion of the hemostasis, which will be confirmed with Valsalva and raising the blood pressure above the normal, patties are gently removed. There may be a gush of little blood. This was because of collected blood initially. Thorough inspection has confirmed there is a meticulous hemostasis achieved at the surgical cavity, also at the surface. Patient postoperatively had minimal right hemiparesis and speech disturbance, which improved with anti-edema measures, and being discharged within 1 week with the regular follow-up. Post-op imaging showed complete excision. Thank you.